Now, just like the prominence of Ebola in 2013, coronavirus in 2020, the Africa Centers for Disease Control and Prevention has officially declared the ongoing Mpox outbreak a public health emergency of continental security. According to reports from the organization, there had been 38,465 cases of Mpox and 1,456 deaths in Africa since January 2022. The Director General of the organization, Dr. Jean Kaseya, says that this declaration will enable the mobilization of resources across affected countries, unlocking essential funding, strengthening risk communication and community engagement, boosting surveillance, among others, through a One Health approach. The outbreak, which has spread to various countries, is now of international concern, its highest level of alert. Let's talk this through by speaking with a public health consultant who is joining us from our Abuja studio, Dr. Tuyi Mebamodu. Dr. Tuyi, thank you so much for joining us on TVC Breakfast. Let me start off by reading out to you the NCDC confirming 39 cases in Nigeria, Lagos, Ogun, Bayelsa top hit list state, and also epidemic ravaging Africa, 2,863 cases and 517 deaths. So it's actually, it has spread across 70 countries. Those countries reporting the monkeypox cases. But how do you consider the declaration of it being an emergency? What more do we need to know?
Yeah, thank you, Ibrahim. Again, we are faced with germs and what they can wreak on the health system and even the economy of a nation or even the continent. It is heartwarming to know that the African Center for Disease Control on the 13th of this month chose to declare this monkeypox or Mpox as a public health emergency of continental security. And of course, a few days after, WHO came up and said this is public health emergency of international concern. Why is this? We've seen a serial rise in the cases of monkeypox or Mpox since 2022. In 2022, we had just about 7,000 cases. By 2023, it became 14,000. And now we're having more than 17,000 cases with about close to 1,000 deaths already. And then the epicenter is DRC, Congo. And the thing is that we're seeing a lot of challenges in the kind of way the infection is coming up. Because in Kivu, in DRC, we see that an outbreak that occurred was because of sexual transmission of the germs. So we're seeing that the germs can be transmitted sexually. It can be transmitted from mother to child. It can go from person to person. It can come from droplets. So if you see this combination of transmission in a germ, and we're seeing the mutation whereby the clade 1B is becoming more prominent, then we have to be careful. Because in some other situation of other germs, we're seeing that we can only, it was mainly droplet transmission of contact. Then now, it's a combo of transmission routes, body to body, mouth to mouth, skin to skin, animal to human, from materials to human, and then again now we're seeing that it can actually be sexually transmitted and even move from a mother to a baby. So it calls for a serious concern. It calls for a serious concern because, number one, for the past 40 years or more, the global immunity against Mpox has reduced because when we stopped smallpox immunization, it became clear that our immunity to a virus like smallpox will be compromised, and that's what we have seen. And the second thing is that we're now back to what I would call vaccine diplomacy. In the developed country, when the first epidemic went out in 2022, they were able to get vaccines, to counter the disease. But in Africa now, there's no vaccines. We had a promise of 250,000 vaccines from the Scandinavia, one of the Scandinavian countries. Nigeria is getting 10,000 vaccines. But again, what will 10,000 vaccination do to anybody? So we now have to come back to strategic communication and community engagement to ensure that people understand what Mpox is, what are the challenges of Mpox, and how to individually at a community level, prevent Mpox from spreading. So that is where we are now. That is about the best thing we can do, because in reality, we don't have the vaccines in sufficient number. Secondly, we are responding, we are tagging the number, which is very good, but what other response, apart from these announcements, apart from talking about prevention, can we then do? How do we prevent the germs from jumping from one person to another and causing mutation and looking for another route of transmission? So despite all the 5 ones I've listed, that is where we are now.
All right. The fact that we do not have enough vaccine is another source of concern that has been raised by health professionals. But in terms of the severity and the response that should be given to, this current outbreak, how do we compare it to other health emergencies like Ebola and the COVID-19?
Well, it's hard to. It's very nice that right from the beginning we started talking about it. We needn't have to wait till we're seeing the disease all over the world before we start, mentioning and talking about it. Right away, the African Center for Disease Control has declared it a public health emergency of continental security. WHO has declared it as public health emergency of international concern. What this means is that we can now start mobilizing global fund everywhere, start mobilizing human resources, start deepening surveillance and laboratory diagnosis, start mobilizing, response communication, strategic communication to address the disease. So, and that is what we're doing. That is what the tag of global public health emergency of international concern, that's what it does. It's telling everybody, do you have vaccines? Bring for us. Do you have money? Bring for us. Do you have protection? Bring for us. So I think right away, our response is quite apt and quick when we compare to how we responded to COVID-19 initially. And one of the greatest things we need to be careful of is the number of wrong information that may go out, because right now, people are very worried of the vaccination. And when you tell them that you are bringing Mpox vaccine again, what is the thinking? So at this point, we must start, ahead of those conspiracy theories and start talking about what it means for us to get vaccinated, and start talking what it means for us if we deepen our hygiene, and start talking about various modes of prevention. Because what are we talking to? Mouth to mouth, skin to skin, materials, either towels or whatever, sneezing, droplet infection. It can also, be contacted through sexual intercourse and even from mother to child. So that is why we must be on high alert. And anybody with those kind of rashes that looks like monkeypox should be reported. Should even self-report himself or herself, and then isolate until about 4 weeks when the infectivity will reduce.
Well, Dr. Tui, if you look at what the WHO actually reported, they said 98% of reported monkeypox cases are among men who have sex with men. I mean, just about 2 weeks ago, on London Bridge, I saw 2 men, during the Pride Month, I guess, from June and then to July, extended to July, celebrating the Pride Month, where you had man, actually exchanging kiss with a man right on London Bridge, and I found it very disgusting. But then WHO is now saying that 98% of those who, have, coitus, men with men, have been, there's much more cases reported, between them. So how do you think, and then we have this thing also, spreading into Africa, through this practice. So with that, what targeted intervention do you think, are being implemented to address this demographic, and how do we ensure inclusivity in this kind of response?
Ibrahim, thank you. We should be careful not to label or categorize and create more stigmatization and driving our campaign on the ground by looking at some demographic and saying that, look, you are the one spreading this disease. Let us just remove that. Let's be careful about that. Secondly, Mpox, has variants. What we call clades, there's clade 1, clade 2, and then 1B. The one that we see from men to men is actually the 1B. So there's still the other one, which is less virulent, that can affect the general population. It didn't start with men to men or MSM people, but it started as far as 1970. It was even seen in a 9-month-old child. That was the first case in 1970 in DR Congo. So let's be careful, because there are other means, other ways of transmitting the disease. By the time you are trying to, stratify and isolate some people and label them, you can't win such fight against such diseases. And then, even if you are with people like that are with us, it's a reality now. We have to also know that there are other people who are heterosexual, who transmit diseases, of course, mainly even HIV now. And then,
that's right.
And we need honesty to remove that from our conversation. But what we need to do exactly is to deepen this campaign and let people understand that we still have to go back to our basic hygiene, to strengthen community, to look at how we interact with the animals, because if you hunt and you skin animal, you eat animal, the droplets touches the person, while the animal is with Mpox, you're likely going to pick it. In fact, we have to actually do some work in terms of looking at the reservoirs, mainly, monkeys, rodents, squirrels, these are really the reservoir. So for us, we need to heighten the vaccination, apart from the campaign, find a way to heighten the vaccination, call for help from the various organizations and agencies that feed into our health system. That is what we must start doing now. It's wonderful that we're having the traction now. We have to continue the conversation, because without us continuing the conversation, we lose the track, and then until the disease now, find itself with us again. So that, for the cheapest thing we can do now is to deepen the conversation.
Perhaps transparency and accountability should be, some of the factors that should be considered in this. With the figure that has been released in Nigeria, so many persons are still having difficulty believing this. But for the purpose of, public enlightenment and education, what are the clinical manifestations of this, and at what point do you have to present with these symptoms to the hospital?
Well, thank you. Of course, when the incubation period of Mpox is actually between 1 and 21 days. Now, the first thing is actually those constitutional symptoms: headache, muscle ache, sore throat, a large lymph nodes. After some days, then we see the appearance of rashes. It appears from the face first, spread to the arms, spread to the legs. Okay. The rashes are actually bigger than smallpox rashes. Okay, of course, smallpox has been eradicated 40 years ago, so a lot of people may not actually know what smallpox is. But it's like a bigger rashes with central depression. And now it starts initially to be flat, it becomes raised with water inside, then there's pus inside, it breaks off on a form crust and fell off. So during all these stages of the evolution of the rashes, it's still infective. Can still transmit the virus from one person to another. So then what happens is that secondary bacterial infection can set in. It can then, lead to a lot of challenges, shut down the immune system, shut down the blood system, and then cause death, leads to death. Of course, the type 1 mortality rate is actually up to 10%. That's quite a large number. And if you look at Africa, where we have a lot of children, or younger population, which are the targets, where we have quite a lot of undernourished people. Nigeria is an example with high level of malnutrition. The chances of developing the fatal form of this Mpox is highest. Now we have interaction with other viruses. We're still dealing with Lassa fever. We're dealing with even COVID-19 silently. We're dealing with HIV. The interaction of these germs with all these things is also a cause for study, because in reality, they tend to enhance themselves and bring out the worst form of this virus. So that is why, as we are now, we've had enough of cholera is ongoing. We've had enough of cholera. We've had enough of Lassa fever, which is still ongoing. We cannot add Mpox to it. And for all of us, everything you can do at your corner to prevent, picking these germs, you need to do. If you are a hunter, we need a special education for hunters, because that is where a lot of those germs jump from animal to human. If you are in a community at the level of local government, we need to expand the communication and talk about early symptoms and signs of Mpox.
Interesting stuff. You talked about the vaccine issue, because vaccine equity has been a concern with limited access to Mpox vaccines, talking about low and middle income countries. Even if we have enough vaccines to go around, there are still some people with the vaccine hesitancy, mindset that, the intention of the vaccine is not positive, not just the Mpox vaccine, but other vaccines that are available out there, in the market, available for people to have access to. But what would you say that people need to have at the back of their mind, especially exploring the non-pharmaceutical measures in making sure that they do not contract this Mpox, which is now spreading fast? Having Lagos to report a case, and also Bayelsa and some other states in Nigeria. So what are the non-pharmaceutical measures that we need to have at the back of our minds to explore?
The first thing we need to do is that we need to talk about it, communicate, let it be clear to people how these things, the signs and symptoms, how it manifests, and how dangerous it could be. Now, because information is the starting point of action. So, secondly, we need to still embrace our hygiene. You can't overwash your hand. You can't, you have to avoid, crowded places. And then, for all of us who, I've observed that there are quite a lot of people with allergies and sneezing nowadays. Try to cover your nostrils when you have to sneeze in a public space. Of course, if you don't have reason to be in a crowd, avoid crowd, and we have to actually put a lot of focus on our markets, and our rural areas where we have a lot of interaction between animals and humans. So these are some of the things. Of course, the normal preventions for people who must not have unprotected sex. That's forgiven. It saves a lot of you from a lot of problems. So these are the general hygiene. Actually, hygiene rules also cover for a lot of diseases. But in this regard, even if we have vaccines now, of course, you pointed out the hesitancy is the big issue. We need to start communicating, because even in terms of the great health system we're trying to build. Recently, the federal government spoke about the way to mitigate the doctors' migration. Well, if you do that, you still have people to come to your center, to trust your system, to take your vaccines. You have to communicate with them. You have to give health literacy at this point. We're not communicating critical decisions in our institutions to our people enough. What is dominating the media space is actually politics and TikToks. So for me, it's time to also deepen communication very well in everything we're doing and how we're trying to keep people healthy. So we're here. We will continue. And then, of course, let's commend the Center for Disease Control for the wonderful job they've been trying to do. They are trying to do in telling us and even trying to keep surveillance, even at the border, whether you're entering Nigeria through footpath or you're entering through ship, or especially from those countries with high cases. That DRC is very close to a lot of places in Africa, East Africa, West Africa, and a lot of countries in Central Africa, Uganda, Kenya, Kigali, that's Rwanda, and even Burundi. So we just have to actually find solution in Africa way to deal with these diseases through data communication, vaccine mobilization, human resources mobilization, surveillance, early lab testing, and of course, acting when we have a case.
All right, so amongst some of these issues that you have mentioned, you are yet to mention the issue of stigmatization, especially in Africa, to some of these outbreaks. Most times, some persons find it very difficult to present with their symptoms and have to resort to self-care in the long run. So how do we address, or how do we focus or raise more awareness, apart from communications like you mentioned, on the stigmatization of some of these diseases, and how this will help push out some of those that have these symptoms?
Indeed, that was why I was trying to explain to Ibrahim that we cannot look at some demographic and tell them that you are the one bringing disease to the world. It's not going to help in terms of our campaign. It's not going to help in reporting. It's going to help even in fighting those diseases. So that's why, for instance, stigmatization we can reduce it through education, okay? And then encouraging those people who may have any rashes to come forward. We cannot do a general survey in society, but up till now, quite a lot of diseases have been stigmatized. Let us appreciate the fact that we just have about 4 weeks, even somebody with rashes, for the thing to go away. We don't know the long-term effect of it. Once it goes away, the person can resume the normal activities. So education. I mean, specifically health education is one of the key things that can help in reducing stigmatization. And of course, the attitude of the leadership, political leadership to the disease. And if they come and say that, listen, for instance, if we have a number, because disease is no respecter of anybody, maybe we have a political leadership or entertainment leadership or somebody, you know, who is coming over and say, listen, I have monkeypox, I've recovered, I'm good enough, nothing's going to happen to you. Those kind of optics help to reduce issue of stigmatization and self-blame in regards to that. So we cannot finish with, even ordinary tuberculosis stigmatization, sickle cell stigmatization, HIV stigmatization, everything. So I think it's a mindset that needs a lot of work to redress. We won't give up.
In talking about demographic, you know, this is actually a WHO, report. You know, it's not a personal opinion, just like you tried to, address the issue, a little earlier. But then, looking at, leveraging technology, such as the digital contract tracing and that of telemedicine to enhance the response to monkeypox to improve health, outcomes. How do you think we can leverage this to ensure that this is definitely mitigated before it gets, before it becomes widespread beyond what we can control, as we had it, during the COVID-19, during the pandemic era? And you also commended the NSCDC, but I'm not sure how the global health response has been, particularly narrowing down to Nigeria, how much they've responded, and our plans, the lessons we've learned, in planning for future emergency or future public health emergencies.
Yes. First and foremost, let's look at the digital space. In your studio, severally, I've spoken to the health practitioners to be wary, not to neglect social media or even any media at all, because a lot of narrations on social media that will go viral and will be actually falsehood. For you to fight them becomes an issue. So you need to be a step ahead of the people. Now, the digital space, both mainstream and social media, need to be explored. I now expect, as one of the strategies, that even skits can address the issues that have to do with diseases, even this Mpox as it is, and how to respond to it. Some of those skills that can go viral. I expect narrations around some of our films, and of course, and whether Nollywood or whatever would, to actually look into that and see how to drive it. I expect that even our advert spaces should be able to call attention to that. Even in our religious houses, I expect that we should be able to take the message to the pastors, the imams, and traditional religion that, okay, this is the story about monkeypox, this is the story about cholera, this is the story about Lassa fever, and this is what we need to do. And every space, we have to match, those people that spread falsehood in every of those places. We have to actually be ahead of them to communicate. Now, even at the level of the CDAs, which is quite widespread in Nigeria, we must be able to do communication, because, for instance, I know in Lagos that right now they're trying to think of some environmental issues. So use that to also discuss, to talk about monkeypox. If we have flyers, put in strategic places, let people know that in reality there's a new disease called monkeypox. If we are consistent about this, of course, nice, we'll get the necessary traction. And now, to address the response of the international community, I tell you what, initially it's going to be reticent because in reality, some guys develop these vaccines, they develop it purposely because of money. And then one of the greatest challenges to health is actually funding, okay? If you ask CDC, they will tell you that, okay, we are not having requisite funds to address all the epidemics or, in our hands. And that is so true. So what do we do? How do we mobilize funds to the health system and address some of these things? Well, it has to be actually multi-pronged. We are looking up to our partners to do some things, to be able to, develop vaccines, send us some drugs but also the private initiative needs to be deepened to start addressing the depths and the issues concerning pandemics and those diseases as it affects us. So we must be able to look for a mix. But because Nigeria, in a way, we've taught the world how to fight epidemics in the past. Ebola was a living example. Even our COVID, Ebola, our response to Ebola was top-notch, that everybody were coming to Nigeria to learn. How did you do it? What did you do? Even at the level of COVID, the kind of death we're expecting didn't happen. So for us, as we have started quickly, I am sure that this Mpox will also be curtailed appropriately. But we need funding, we need human resources, we need surveillance, we need lab tests, and we have to actually put our best foot forward to counter the spread.
Thank you so much for simplifying this knotty issue, especially when it comes to public health emergency. Public health consultant, Dr. Tuyi Mebandu. Thank you very kindly once again. Thank you.
Thank you.